Hi guys, today's topic about allergic rhinitis or hay fever or allergic rhinosinusitis. It is IG response to the particular allergen leading to hypersensitivity reaction or atopy. It is allergic rhinitis is most common causative agent is house dust mite. Its scientific name is dermatophagotes. It's also called carpet dust mite, or its all second common cause is pollens like ragweed, grass pollens. It may be caused by cockroach, spider, ticks, cat. These are the another causative agent leading to allergic rhinosinusitis or allergic rhinitis. As you know, this house dust mite feeds on the dead epithelial cells of our body. On the bed, if dead epithelial cells are falling in this carpet dust mite is eating it. So these house dust mites feeds on dead epithelial cells of our body, and this is the house dust mite. It seems to be spider-like or tick-like. It is from the spider or tick family. It is just like them only, and size about 400 to 300 micrometer in size. We can see only microscopic vision. Maybe near future mobile coming in that resolution we can see on this mobile camera also after maybe 10 year afterwards. The IG related TRAD, most common TRAD is allergic rhinitis, asthma and atopic dermatitis. In these house dust mite can be killed by sunlight, ultraviolet, petrol wash, boiling. So we have to wash each and every household or like bed sheet, curtain, carpet every weekly so that we have to prevent from the allergic rhinitis. Allergic rhinitis more common in male than the female. More common on smoker than non-smoker. More common in urban area and high socioeconomic class because of hygiene hypothesis. You can see hygiene hypothesis is if you are exposed for allergen during your childhood, there is less likely to develop allergy later on in life. So it is more common in higher socio-economic class because they are maintaining hygiene. So what is hygienic hypothesis is there is more T helper cells. So shift is from T1, T2, T2 helper cell to T1 cells. So these T1 helpers are more having antibodies by activation of B cells. So that's why shift from T2 to T1 helper cell will develop hygienic hypothesis so that the whoever child from childhood exposed to all allergen less likely to develop allergic rhinitis later in their lifespan. So allergic rhinitis is two types: intermittent or persistent. Intermittent if it is less than 4 days in a week, less than 4 days. 4 weeks, less than 4 weeks. It is less than 1 month. If persistent, if it is more than 4 days a week, and it is not or and more than 4 weeks. So duration is more than 4 days in a week and 4 week more than 4 weeks. So this is intermittent or persistent type. According to degree of severity, it is two types: mild and moderate to severe. Mild is already normal activity one can do with allergic rhinitis, but moderate to severe type is having abnormal activity like sleeping, daily work disturbance, school, troublesome symptom are having moderate to severe type of allergic rhinitis. If you see allergic patient coming to your OPD, you can see by allergy facing like open mouth, allergic sinner, repeated sneezing, Denny Morgan lines. These allergic shiners and Denny Morgan lines are situated below the lower eyelids. You can see dark lines. Allergic salute, there is transverse crease on the dorsum of the nose by repetitive upward movement of the nose during sneezing or nose cleaning. So diagnosis mainly by the clinical. If you see diagnosis mainly clinical, supported by the endoscopy like pale bluish hypertrophic mucosa on endoscopy. If it is red congested mucosa, it is sign of acute infective sinusitis or acute bacterial sinusitis. Infective red and pale blue is suggestive allergic rhinosinusitis. The Skin prick test, intradermal skin prick test is diagnosis of choice. You can see there is flare reaction over the more than 5 mm size on the skin, mainly ventral aspect of the hand. The nasal allergic challenge test is also provocative test. It is gold standard test, but not routine needle because of difficult to standardize it, difficult to done it, and not done routinely because of it's only for research purpose and there is chances of anaphylaxis also. So nasal allergen challenge test is gold standard but not routinely run, and skin prick test is diagnostic also. It is two intradermal test or you can use subcutaneous test. So intradermal test is diagnostic of choice. Now etiopathogenesis, if it is see this is antigen leading to represent on the membrane bound IgE receptor on mast cell through antigen presenting cell or dendritic cells. So within 2 minutes of exposure it releases histamine, prostaglandins, leukotrienes, platelet activating factor, thromboxane A2, tumor necrosis factor alpha, eosinophil chemoattractive factor heparin are leading to acute phase reaction like wheezing, sneezing, urticaria, conjunctivitis, nasal pruritus, nasal discharge. These are the acute phase sign within 2 minutes of exposure of allergen. After some time, there is delayed reaction which lead by interleukin 4 and 13, which leading to IgE production, which ultimately activate mast cell, which release the delayed mediator like leukotrienes and platelet activating factors, which occur after 4 to 6 hours of exposure, which lead like eczema, nasal obstruction, hypertrophy, postnasal drip and cough. If you see treatment of allergic rhinitis, according to Allergic Rhinitis and Impact on Asthma Society area guideline, if mild intermittent you have to just avoid the allergens. No specific treatment is required except avoid the allergen. Only you can give non-sedative antihistaminic because it is mild intermittent. For the moderate severe and mild persistent, moderate severe persistent, you have to give intranasal steroid for long term because it is the safe and very effective. It's because intranasal steroid cover all phases like in this histaminic phase, prostaglandins, leukotrienes and platelet activating factors. So all are inhibited by steroid. But if you are giving antihistaminics, this only inhibits the histamine. So sometimes you are giving antihistaminic, even sedative antihistaminic, patient is not relieved because patient develops severe allergic rhinitis not involved by histamine only. We have to cover these prostaglandins, leukotrienes, so we have to give sometime steroid in added doses with antihistaminics. Okay, so this is the funda behind the adding the steroid in severe cases. So treatment of choice is intranasal steroid. Permanent cure is immunotherapy. You can say desensitization therapy. Okay. Now, food. Which food we have to avoid in allergic rhinitis? Alcohol, dairy milk, meat, and bread. And fruits. What should we take? The benefit of the diet we should give in allergic rhinitis. Fruits and vegetables are helpful because they are having quercetin like plant flavonoids which inhibit the mast cells. So it is commonly found in the onion, apples, berries, tomato. So these fruits are very helpful in allergic rhinitis. We should recommend these fruits: onion, apple, berries, tomato. Vitamin C also helpful. It's found in the broccoli, Brussels sprouts, citrus fruits. So it's also inhibit the histamine release. Fish and fish oil which having omega-3 fatty acid which also inhibit the T cells, and this is helpful. Ginger also reduce T cell responses like late phase responses in allergic rhinitis. Curcumin and turmeric powder also helpful in the interleukin inhibition in the allergic rhinitis. So prevention of house dust mite, cockroach, animal dandruff, mold, pollen are also helpful to you have to keep home clean. Immunotherapy is also called allergic specific immunotherapy is two types: subcutaneous immunotherapy and sublingual immunotherapy. It is the permanent cure. The patient who want to cure relieve permanently or who want not relieve by other medication like steroid and histamine, you should recommend the immunotherapy. It is desensitization over 2 to 3 years, and this is ultimately lead to immune tolerance. So this is the all about allergic rhinitis. Thank you so much.